difficult to follow. So for those who are interested, this is the latest 2009 ACC/AHA focused update on the use of beta blockers. It is available online, free. So you can download it and read it properly. But the take-home messages from this update are, number one, start beta blockers at least a week prior and titrate dose to reduce the resting heart rate between 50 and 60. That is one. Two, bisoprolol, atenolol, and metoprolol are the three most widely tested beta blockers. Do not use fixed high-dose, slow-release preparation like metoprolol extended release 100 milligrams. Don't use that. Because you will never be able to titrate it post-operatively when the hypotension occurs or bradycardia occurs. You will never be able to titrate it. Do not start 24 hours pre-op. So if the patient is not on beta blockers, lands up with you for emergency surgery, you have no scope of starting him on a beta blocker. It's as simple as that. Because the most important trial called POISE. POISE trial started beta blockers 24 hours pre-op in a large sustained release metoprolol 50 to 100 milligram. It increased mortality and increased post-operative stroke incidence. So it produced harm, forget the benefit. So please go through at least these three studies, DECREASE, POBBLE, and POISE. And not to add, not the least, McGaudy's meta-analysis. These four, if you read, you'll be thorough about when to use a beta blocker, how to use a beta blocker. But the number needed to treat are, you need to treat 8 patients to avoid perioperative ischemia, 23 for perioperative MI, and 32 for cardiovascular death. So number needed to treat is the magic mantra today for any trial, and the number needed to treat are far too small. So the benefit is quite large.
Dr. Ponde, in that one, just want to,
yes.
one small thing. Like the POISE study said that if you start 24 hours prior, the mortality is more.
Yes.
And also we said that bringing down the heart rate in the perioperative
yes.
and the intraoperative period decreases one important factor, the tachycardia, which is producing perioperative myocardial ischemia. So do POISE study can be extrapolated in the perioperative period, or is it still worthwhile starting them on beta blocker to take the heart rate down?
Within 48 hours, you mean?
Within 48 hours.
See, unfortunately, like every good thing has a price to pay. Beta blockers have two prices that we normally pay. That some degree of sympathetic tone that is required to stand stress is cut off by the beta blockers. And when it is cut off acutely, you will have post-operative hypotension and probably cerebral deautoregulation. That is what the POISE people have contemplated. So acutely giving a large dose of beta blocker to bring the heart rate down in the immediate preoperative period, like 24 or 48 hours, is not an acceptable thing. Now you'll ask me, is there any other choice? Yes, and I was going to come in my next couple of slides in that. The best drug today available is ivabradine. Ivabradine is a direct sinus nodal inhibitor. It only inhibits sinus node, has no effect on AV node, has no effect on blood pressure, no effect on bronchi, and no effect on hemodynamics. So if you want to bring down the heart rate, you just start ivabradine 2.5 to 5 milligram twice a day. Very safe, no effect whatsoever on hemodynamics, purely cuts down the heart rate. And you will be able to bring it.
How fast it works?
It works within 6 hours. So there is unfortunately, there is no a randomized trial, but there is a 3-center big study which has appeared, including around 375 patients with ivabradine, as a subgroup analysis of SHIFT trial. And in this subgroup analysis, they showed that starting ivabradine even as early as 24 hours preoperatively does help to cut down the heart rate and perioperative ischemia in cardiac patients. And could be a safe alternative to beta blockers which cannot be given immediately. And larger studies are needed to prove this point. So I think there is a choice there.
Yeah, ivabradine, is it commercially available
Absolutely.
now?
There are 3 brands. Aina Pure is one brand, Ivabrad is another brand, and Coralan is the 3rd brand. There are 3 companies making it.
And when do you suggest, for a case scenario like this, when do you decide to start on ivabradine?
Suppose the resting heart rate is 90 plus, and you have taken care of pain, you have taken care of anxiety, you have partially sedated the patient, and the rate still remains high, and the patient has background of ischemic heart disease, I would be keen.
So heart rate cutoff is 90.
Heart rate cutoff is mandatory. Now going to Dr. Gopal's question about statins. Statins are associated with reduced incidence of perioperative mortality in patients undergoing major non-cardiac vascular surgery. And besides cholesterol-lowering properties, statins have anti-inflammatory effects and stabilizing properties on the plaque. Retrospective data on more than 2,800 patients suggests that they reduce mortality. A prospective study of 100 patients, atorvastatin 20 milligram OD for 45 days prior to surgery decreased cardiac events. Current data suggests that 80 milligram 2 doses also preoperatively are as good as starting it 15 days preoperatively. So that answers your question, sir, I think. That if the patient comes and you give on the prior night 80 milligram, or on the morning of surgery 80 milligram, that produces pleiotropic effect, non-cholesterol lowering, plaque stabilizing effect, and reduces the incidence of perioperative MIs. Question to Dr. Bala. How will you give postoperative analgesia to this patient?
I think we need to follow the principle of multimodal analgesia in this patient. And one definite component will be regional anesthesia. And if you had put an epidural catheter, one would be to continue the epidural analgesia in the form of an infusion, not in the form of a bolus dose, which has got the propensity to produce hypotension. Best thing is to do in the form of infusion, number one. Number two, the other option is available is put a continuous femoral catheter and also put an infusion. Then along with the regional technique, always think of paracetamol, non-steroidal anti-inflammatory drug if there is no contraindication, especially diabetic and renal parameters are okay, non-steroidal anti-inflammatory. And the third one will be, now a lot of trials have shown using gabapentin and pregabalin in the perioperative period as an analgesic. The next drug is Decadron. The steroid has been found to accentuate the pain relief in these patients. And to this, if needed, opioids. But if you use a multimodal in the previous components, the requirements of perioperative opioids decreases, and hence the side effects to the opioids decreases.
Oh.
Yeah, tramadol is another drug which definitely it comes the combination with tramadol with paracetamol. The only problem is the nausea and vomiting with tramadol is high, especially in a geriatric population. So that's an individual opinion and based on the availability of other drugs, but definitely for sure is paracetamol, non-steroidal, pregabalin, and steroids. Yeah, actually the dose now it is prescribed as 75 milligrams of gabapentin once a day. Now there's become, few trials have come with this being used as a pre-medication also. Statin and pregabalin or gabapentin in the pre-medication continued for the first 4 days when the pain scores are very high.
What about the dose of steroids and in diabetics?
That's
How many more minutes? Yeah.
The dose of steroids and
10 more.
Yeah,
Alright.
that's actually, like it's a marginal, most of these patients are on a control regimen of insulin. So steroids definitely would increase the sugar to a
insulin
certain
requirements,
extent,
yes.
but then I think it could be easily controlled.
I don't think that's a big issue because here when we start steroids for, let us say, obstructive airway disease, hydrocortisone and all that, the insulin requirements definitely go up. You need to titrate them, that's all. So this is the epidural infusion, 2 types of infusion, Dr. Bala.
I think we'll go to the next slide. They're all
Okay.
pundits in this.
Is postoperative pain relief important to reduce the major adverse coronary events? Yes. There is a decrease in postoperative tachycardia and catecholamine surge, thereby decrease in the postoperative ischemic events. There is a decrease in hypercoagulable state because of regional anesthesia. Epidural anesthesia decreases platelet aggregability also. And just now, sir said that epidural anesthesia also improves the diastolic relaxation properties of the ventricle. Please remember that. It's a very big advantage of an epidural catheter there. Less and less need for opioids and NSAIDs, thereby decreasing respiratory complications, renal complications, and antagonism to aspirin because of NSAIDs. So all these are very big advantages of regional techniques in a cardiac patient. Dr. Bala, could you give any guideline about removal of the epidural catheter, because this patient will be definitely on a low molecular weight heparin post-operatively, isn't it?
Yes, actually, this slide we can skip and go to the next case because this is available in the net.
Alright.
And I think all of you know about the ESRA guidelines on removal of the catheters.
Anyway, I just had a second case, which was a 68-year-old male, non-diabetic but hypertensive, history of unstable angina 1 year ago, and had 2 stents, LAD and circumflex. Both are drug-eluting stents. This is Cypher, made by Johnson & Johnson. This is Xience, made by Guidant. Right coronary had a diffuse disease and therefore was left alone. Normal left ventricular ejection fraction at rest. Free of angina now. 1 year back, angioplasty with true drug-eluting stents is on aspirin, clopidogrel, metoprolol, and a statin, posted for an elective TKR. Problem is aspirin and clopidogrel. The problem is aspirin and clopidogrel. And this is one article which came earlier in 2007, catastrophic outcomes of non-cardiac surgery soon after coronary stenting. What do you mean by soon? Within 3 months. So within 3 months after a drug-eluting stent, there's no question, patient cannot undergo an elective non-cardiac surgery. Coronary artery stenting and non-cardiac surgery, a prospective outcome study which came in British Journal of Anesthesia in 2006. And finally, 2007, one more study and a review of all this in Indian Journal of Anesthesia by Usha Kiran. What is the message? Elective non-cardiac surgery after angioplasty with bare metal stents should be delayed for at least 8 weeks or possibly 6 months. When the bare metal stent endothelize fully, and you can stop aspirin and clopidogrel for a period of a week or so without any hassles. But elective non-cardiac surgery after an angioplasty with a drug-eluting stent should be deferred at least a year. And this stands true even today. The data from 2009, even today, there is no change in this recommendation from the ACC. They say that after a drug-eluting stent, if you have a choice, delay the surgery for 1 year. And therefore here, bare metal stent, less than 30 to 45 days, proceed. And if you have emergency surgery, proceed with aspirin. Between 30 to 45 days, delay it. And drug-eluting stent, less than 365 days, if you need a surgery, try to delay it. Above 365 days, proceed in the operating room with aspirin. That is very, very important statement, because even after 365 days, few struts, as many as 11% of the struts of a drug-eluting stents are not endothelized. And they can expose the patient to subacute stent thrombosis, which is in 50% of the time a fatal event. The fatality of subacute or acute stent thrombosis because of withdrawal of antiplatelet therapy is 50% in the best centers in the world. So it is not a small thing. It's not a simple thing to handle. So please continue aspirin.
Dr. Ponde, aspirin, do you want to say the dose, safe dose to continue, even if
150 milligrams.
150
not 75. 150 milligrams. And this is the SAVRA guideline of 2007, which stands true even today, in conjunction with the ACC AHA, that no contraindication with NaCID or low-dose aspirin. Discontinue ticlopidine. Ticlopidine is now out. Discontinue clopidogrel 7 days prior for a central neuroaxial anesthesia. Tyrofimab at least 12 hours, and absaximab at least now 48 hours. Absaximab is platelet receptor antibody, the stronger platelet. This is for the guidelines for central neuroaxial anesthesia in patients receiving antiplatelet drugs. So it's like a calculated risk, ladies and gentlemen. It's like bungee jumping, you know. You have to find the right time, right gap. So after a PCI, you have to find the right time to do a major elective non-cardiac surgery. Yeah. Yeah. Yes. Clopidogrel after 1 year, you can discontinue as long as a week. We have to continue both of them, unfortunately. Yeah. Now, going to